In this video, we shall discuss about metabolism, otherwise called biotransformation. Now, in previous videos, we discussed that pharmacokinetics basically deals with what the body does to the drug. Exactly what or how the body absorbs, distributes, metabolizes, and excretes the drug. It's important to know that pharmacokinetics also involves two parameters, two primary pharmacokinetic parameters, and they include clearance and volume of distribution. Now, in this video, we shall discuss about metabolism in greater detail. Now, to discuss about metabolism, we need to define the term xenobiotic. Now, the term xeno essentially means foreign. So, if we call a person xenophobic, that means that this person is uncomfortable with people of different races or foreign races. So a xenobiotic essentially means something that's foreign to the body. It can be some sort of food additive, or cigarette smoke, or drugs, things of this nature. Now, it's often erroneously defined that metabolism means the inactivation of xenobiotics, but this isn't always true. Now, there are instances where an inactive drug or a pro-drug is metabolized to an active form. The most famous example is that of levodopa. Levodopa by itself is something that has no activity whatsoever. It's a pro-drug. But it passes through the blood-brain barrier, enters the brain, where it gets metabolized to dopamine, which is very useful in the treatment of Parkinson's disease. Now, of course, there are examples where drugs get inactivated as a result of metabolism, and this includes the vast majority of the drugs. A good example would be succinylcholine. Succinylcholine is a skeletal muscle relaxant, or probably more accurately described as a neuromuscular blocking agent. It is metabolized by an enzyme which is known by three names: pseudocholinesterase, or plasma cholinesterase, or butyl cholinesterase. These are three names for one and the same thing. Now, there are certain instances where an active drug is metabolized to a metabolite which is also active. And the example for this would be a benzodiazepine called flurazepam. Flurazepam is a sedative hypnotic. This is a drug which is used for the treatment of insomnia. Flurazepam gets metabolized to other metabolites, and these metabolites also have got sedative hypnotic properties. So, metabolism doesn't just mean inactivation of xenobiotics. It's more correctly defined as the chemical conversion of one species to another, one chemical species to another. Now, the metabolism of drugs occur mostly in two phases, phase 1 and phase 2. Now, in phase 1, the activity of the drug is changed and a functional group is usually added. Now, this prepares the drug for phase 2. Now, in phase 2, what essentially happens is that the drug is made lipid insoluble. And when the drug becomes lipid insoluble, it fails to pass through biological membranes. And this means that at some point or another, this drug is going to find its way out of the body and it's going to get excreted. So, in other words, phase 2 reactions prepare the drug to get excreted. That's the next pharmacokinetic process. So this is how it happens in general. Of course, there are plenty of exceptions, but this is the general framework of how it happens. Now, there are many phase 1 reactions, the most important of which include oxidation, reduction, and hydrolysis. We shall focus more on oxidation. Now, oxidation reactions occur with the help of three groups of enzymes. Now, the first group of enzyme includes the cytochrome P450 monooxidase group of enzymes, the cytochrome P450 group of enzymes. There are two other groups of enzymes which we shall conveniently ignore. Now, the cytochrome P450 group of enzymes are of two types, mitochondrial and microsomal. The mitochondrial group is not involved in metabolism, it is more involved in steroid hormone synthesis. We shall not be discussing that group any further. The microsomal mixed function oxidases are of two types, the cytochrome P450 monooxygenase group of enzymes and another group of enzyme that we can conveniently ignore. So, the discussion boils down to this. Phase 1 reactions include oxidation, reduction, hydrolysis, and some other reactions which we are not mentioning. Oxidation reactions are carried out by three groups of enzymes, the most important of which is the microsomal cytochrome P450 monooxygenase group of enzymes. Now, large groups of enzymes are sometimes referred to as superfamilies. Right. So, the cytochrome P450 monooxygenase system is a group of enzymes or a superfamily. And the enzymes in this superfamily may be grouped into various families. The enzymes in any given family can be grouped into subfamilies. And each subfamily consists of individual enzymes. Now, there is a nomenclature system for the various enzymes in this superfamily, and we need to be familiar with it. So, any enzyme belonging to the cytochrome P450 monooxygenase group of enzymes or superfamily is given the notation CYP. Now, we know that enzymes belonging to this superfamily can be grouped into different families, and each family is given a notation, a number. Again, we know that enzymes belonging to any given family can be grouped into subfamilies, and each subfamily is given a notation, a letter. And we know that each subfamily consists of individual enzymes, and each individual enzyme is given a number. Now let's put this into perspective. Let's assume that each vertical line that you see is an enzyme, and this comprises the superfamily, the microsomal cytochrome P450 superfamily of enzymes. Now we know that the enzymes in this superfamily can be grouped into various families. Let's consider three families, family 1, family 2, and family 3. We know that the enzymes in each family can be grouped into subfamilies. So let's consider subfamily A, subfamily B, subfamily C, and subfamily D. It can go on to E, F, G, H, and so on. But for now, for the purpose of this example, let's consider these. So these are the subfamilies seen in family number 1. Similarly, we can do the same for family 2 and family 3. Now, let us assume that I wanted to identify and name this particular enzyme, the enzyme marked with the yellow cross. Now, this is an enzyme which belongs to the cytochrome P450 monooxygenase system, and therefore I need to give it the notation CYP. Since it comes in family number 3, I need to put a 3 over there. It comes in subfamily A, so I need to put an A. And this particular enzyme is enzyme number 4 in subfamily A, and therefore this enzyme should be named CYP3A4. Now, you can name any enzyme in this superfamily in this particular fashion. So you can have CYP2C9 or CYP3D1 and so on. So there are plenty of permutations and combinations which can happen. CYP3A4 happens to be the enzyme that is responsible for the metabolism of more than 50% of all clinically used drugs. Now, it's important for us to know that the metabolism of drugs in phase 1 may be altered in 2 ways. Now, there are certain drugs that can cause increased activity of the enzymes belonging to the CYP450 system. Such drugs are called enzyme inducers, and the phenomenon is called enzyme induction. On the other hand, there are other drugs which can cause decreased activity of enzymes of the CYP450 system, and these drugs are called enzyme inhibitors, and the phenomenon is called enzyme inhibition. Now let's take an example for this. Drug A. Let drug A be a drug that is going to induce one of the enzymes in the cytochrome P450 system. Let that enzyme be CYP3A4. So by inducing CYP3A4, it is increasing the activity of CYP3A4, which would mean that any drug metabolized by CYP3A4 is going to get metabolized faster. Drug A would be called the enzyme inducer, and any drug whose metabolism is increased as a result of drug A would be called a substrate. So this is what you would call a drug interaction. There are 3 very important drug interactions of this nature, and we need to be familiar with all 3. The first one is with regards to phenytoin. Phenytoin is an anti-epileptic drug. Now, if there is a patient who is on oral contraceptive pills, and this patient is prescribed phenytoin, phenytoin is going to increase the activity of CYP3A4. And CYP3A4 happens to be the enzyme that metabolizes oral contraceptive pills. The plasma concentration of oral contraceptive pills is going to fall. This is going to lead to contraceptive failure. So this is one important drug interaction that we need to be familiar with, and it's an example for enzyme induction. Another important example that we need to be familiar with is the example of rifampicin. Rifampicin is a drug given for tuberculosis. Now, if a patient is diagnosed with tuberculosis, it's prudent to investigate the patient for the existence of HIV as well. Now, if the patient is also suffering from HIV, then this patient needs to be prescribed antiretroviral drugs. And one important example of an antiretroviral drug is the non-nucleotide reverse transcriptase inhibitor, nevirapine. Nevirapine is a substrate for CYP3A4, and rifampicin happens to be a very powerful inducer of CYP3A4. If these drugs are co-administered in the same patient, it is going to result in antiretroviral therapy failure. Another very important example of enzyme induction is the example of phenobarbital. Phenobarbital comes under the group of drugs called barbiturates. Phenobarbital is an example for an anti-epileptic drug. It's a powerful enzyme inducer, and it will induce just about anything, including enzymes which are not even part of the CYP system, like for example DALA synthase or delta aminolevulinic acid synthase. This explains why drugs like phenobarbital are absolutely contraindicated in patients with porphyrias. Now let's move on to enzyme inhibition. Now, let's assume that there is a drug called drug B now. And let's assume that drug B inhibits one of the enzymes in the CYP450 superfamily. Let's assume that that enzyme happens to be CYP3A4 again. So the activity of CYP3A4 is decreased. This would mean that any drug metabolized by CYP3A4 would be metabolized slower. Drug B would be called the enzyme inhibitor, and the drug whose metabolism has been slowed down by drug B would be called the substrate. So there are plenty of drugs which act as inhibitors of CYP3A4. Some of the more important examples include ketoconazole, which is an antifungal drug, macrolides, which are a group of antibiotics, and a very important drug called ritonavir, on which we should focus our attention now. Ritonavir is a protease inhibitor. It is an antiretroviral drug used for HIV. It's a second-line drug, and ritonavir has got powerful antiviral activity at a dose of 600 milligrams. The unfortunate thing about this is that at 600 milligrams, ritonavir produces a lot of diarrhea and gastrointestinal upset. In spite of this, ritonavir is still a very important second-line drug in the treatment of HIV. It's probably the most important drug in the treatment of HIV as a second-line drug. That too at 1/6 of its therapeutic dose. Now, we're talking about doses of 100 milligrams now. Now at 100 milligrams, ritonavir has hardly any antiviral activity. So what's the explanation? Ritonavir happens to be one of the most powerful inhibitors of CYP3A4. So, if I were to, for example, administer a patient with lopinavir, which is another protease inhibitor for HIV, lopinavir gets metabolized by CYP3A4. But if I were to co-administer ritonavir, not at 600 milligrams, but at a far lower dose, 100 milligrams. Now at this dose, ritonavir is not going to have any significant antiviral activity, but it will inhibit CYP3A4. And this would mean that the plasma concentrations of lopinavir would be increased for a prolonged duration of time. The net result of all of this would be that a lower dose of lopinavir or any other co-administered drug would be sufficient to produce the same therapeutic effect. And since you're using a lower dose, you can expect less adverse effects. So, ritonavir is rarely used for its antiviral effect, but it is very frequently used for its effect as a pharmacokinetic enhancer. Right, we now come to phase 2 reactions, the examples of which include glucuronidation, sulfation, N-acetylation, glutathione conjugation, and methylation. So with the help of these reactions, the drug is made lipid insoluble and finds its way out of the body. It prepares the drug for the next pharmacokinetic process, namely excretion. Glucuronidation occurs with the help of an enzyme called UGT, the full form of which is UDP glucuronyl transferase. Of course, UDP stands for uridine diphosphate. It's a nucleotide like ATP. Sulfation occurs with the help of an enzyme called SULT or sulfotransferase. Glutathione conjugation occurs with the help of glutathione S transferase. N-acetylation occurs with the help of an enzyme called N-acetyl transferase, of which there are two isoforms, NAT1 and NAT2. Methylation occurs with the help of methyl transferase. Right. Now regarding glucuronidation, any discussion about glucuronidation would invariably lead to a discussion on chloramphenicol. Now, chloramphenicol is a broad-spectrum antibiotic, which means that it can kill a wide variety of bacteria. Normally, chloramphenicol is metabolized by UGT. But in neonates, UGT is poorly developed, and therefore neonates are not going to metabolize chloramphenicol that well. The result is that chloramphenicol is going to accumulate and result in a syndrome called gray baby syndrome. Please note, 4 out of 10 neonates who develop gray baby syndrome will die. The neonate turns gray, the color of powdered ash, and the cause of death is usually hypothermia. Now, regarding glutathione conjugation, a lot will be spoken about regarding glutathione in different discussions about the role of reduced glutathione in drug-induced hemolytic anemia. But that's for another discussion. Here, we shall focus upon the use of reduced glutathione in phase 2 metabolic reactions. Now, glutathione is a protein which is found almost in all cells. Drugs may combine with reduced glutathione in the presence of glutathione S transferase to form conjugated products or conjugates, which are harmless and can be excreted. A good example of this would be the metabolism of paracetamol. Now, 90% of an ingested dose of paracetamol is metabolized by glucuronidation and sulfation. The remaining 10% is metabolized by CYP2E1. Now, this results in a toxic metabolite called NAPQI. Now, NAPQI, under normal circumstances, gets conjugated with reduced glutathione in the presence of glutathione S transferase to give a conjugate called mercapturic acid. This is harmless and gets excreted in the urine. However, when toxic doses of paracetamol is ingested, this 10% becomes significant. The reduced glutathione may get depleted, in which case NAPQI fails to get conjugated to mercapturic acid. NAPQI accumulates, attacks the liver, and causes hepatic necrosis. Right. Finally, we come to acetylation. The drugs metabolized by acetylation include sulfonamides, which are antibiotics, hydralazine, which is a vasodilator, isoniazid, a drug used in the treatment of tuberculosis, and procainamide, which is an antiarrhythmic drug. As discussed earlier, acetylation occurs with the help of N-acetyltransferase, of which there are two isoforms, NAT1 and NAT2. Now, normally, any given patient should have both NAT1 and NAT2, and such a patient would be called a rapid acetylator, and this is normal. Such a patient would be less likely to develop adverse effects as a result of taking drugs which are metabolized by acetylation. On the other hand, a patient who has NAT1 but is deficient in NAT2 is more susceptible to adverse effects when administered drugs which are metabolized by N-acetyltransferase. For example, a patient on isoniazid would be more prone to develop peripheral neuritis, and a patient who is on sulfonamide antibiotics would be more prone to develop hypersensitivity reactions. Right, so that's regarding metabolism in brief.